Thank you, ma'am.
Yeah.
Uh, so, so my job is to talk about a young person with endocrine hypertension. So the definition of young is very variable, but we'll keep it below 40 years. So I'm qualified to be elder enough to give the talk. So all this would be based on our experience of managing the patients at KEM hospital and the way we approach it. So when I was doing MD medicine, whenever it comes to hypertension, either a cardiologist will own it or a nephrologist will own it. So it's a domain of heart or kidney, but we all know the truth lies something in between. And what lies between heart and kidney is an adrenal gland, and that's why the adrenal gland is a seat of endocrine hypertension. And I'm not just saying that, I may be able to justify at the end of my talk this thing. And we were talking about stress eating and all. Can I take away the timer, please? It's blocking the slides. I can stop it. Tejal, you can tell me when my time is over. I'll hide it. Yeah. So the adrenal gland, which is, we were talking about stress eating and all. Adrenal gland is a gland which makes 4 hormones. One is sugar hormone, salt hormone, sugar hormone, sex hormone, and stress hormone. So these are the 4 hormones made by the adrenal gland, and they're needed for species survival. So that's what we were talking about, stress eating. So when I am in stress and I have a question of my survival, if I get a surge of sugar hormone and sugar, I'll survive that moment. So that's why these are the 4 sins, which are salt hormones, sugar hormone, the sex hormones, and the stress hormones, which are needed for a species survival. But as a species survival, we need to adapt. But when it leads to maladaptation, it leads to all the problems. So we need all these hormones. Excess of these hormones will lead to hypertension. And because it's a renin aldosterone axis, the renin is made by the kidney and the aldosterone is made by the adrenal gland. And there is a negative feedback, like we have T3, T4 and TSH axis. It is a renin aldosterone axis. So a low renin hypertension is always endocrine for sure, because in that case we have to look at high aldosterone and a low aldosterone pathways. But if the renin is high, the whole pathway is upregulated. That is more like essential hypertension. The metabolic syndrome and the conditions like Cushing's and FeO will also have a high renin hypertension. Starting from the stress hormone is the pheochromocytoma. It's not uncommon as a cause of an adult tumor which may come with hypertension. Like this 11-year boy who came with a seizure episode, blood pressure was found to be 200 by 110. There was a family history in the mother. And a plasma-free normetanephrine was a biochemistry which revealed the diagnosis of pheochromocytoma. CT scan, we can see the bilateral pheochromocytoma brightly lighting up. And a fundus also found in retinal angioma. So it's a syndromic cause of a VHL syndrome. Mother also had spinal and the cerebral hemangioblastoma. So the whole pattern of VHL and the syndromes, I will not go in detail, but it can be part of that. And second common syndrome which happens in the young people come with hypertension and paragangliomas, which happens in SDHB syndromes. And most of these paragangliomas are initially labeled as a tuberculosis. They have been treated with AKT because they have some necrosis. And later on, when the blood pressure comes and someone connects the dot, it is found to be SDHB families, and which can be malignant and multifocal as well. Talking about the test, we have graduated from urinary VMA, urinary epinephrines, to a simple test called plasma-free normetanephrine. Still, many people make mistakes in doing it. It's a supine sample, 30-minute sample. Most of the drugs are okay with it, and it's a plasma-free normetanephrine. And in kids, as compared to the adults, the plasma-free normetanephrines have a different cutoffs as compared to the adults. But the take-home message is it's a plasma-free normetanephrine, a single test which has to be done, and none of the urine and other cumbersome tests are required today. Simple imaging, if MRI would be better in a child, but doing an MRI in a child, it's difficult, it's more time consuming, costly, less available. One time a CT scan is actually a very good investigation if you add an arterial phase to it. and the pheos will bright up, and we can make out a diagnosis of pheo. Even the paragangliomas, which are labeled as tuberculosis or infective etiologies, can be picked up by the same. And as I told you before, the childhood, 50% of them will belong to some genetic etiologies, and the VHL and SDHB are more common, and the cluster 2 pathways like RET and NF1 will be lesser. So this was about the stress hormone pathway. Now shifting to the sugar hormone pathway, which is cortisol. A cortisol excess will lead to Cushing syndrome, and the cortisol will lead to an upregulation of the HPA RAS axis, and the higher renin hypertension will be there in those cases. And this is a child, is a doctor's son. He had an ingrowing toenail, and the staff nurse measured his blood pressure. It was found to be hypertensive. He was first seen by a cardiologist, then seen by a nephrologist, then seen by an endocrinologist who have written obesity is the mother of all illness and has missed the diagnosis. Then when he came to KEM, it turned out to be Cushing's at the end of the day. So that's a story which can go through when we look about cause of secondary hypertension. And ODS cortisol is a simple test to diagnose these cases. After ruling out exogenous Cushing's by doing a basal cortisol, if you do a simple ODS cortisol, and if it is high, the diagnosis is done, and we are lucky we found the adenoma on an MRI. IPSS was not required, and he underwent surgery and RT, and he has been cured of the same. Similarly, like in this series, 40% of the patients of Cushing's can have hypertension, and the classical Cushingoid features and the plethora is very important when we diagnose these cases. And the etiologies of Cushing's can vary with the age. In a younger age, it could be adrenal, like a ACC or a PPNAD, and once beyond 7 years is a Cushing's disease. And sometimes in adolescent age, we can pick up an adrenal adenoma. So conventionally, UFC, midnight cortisol, LNSC, and ODS are the 4 tests which can be done. But at our center, we believe ODS cortisol is sensitive and specific and reproducible and easily doable on an OPD basis. That is what we resort back to. And once the endogenous Cushing is proven, a basal ACTH can guide us towards a CT scan to pick up an adrenal adenoma or a PPNAD, or a MRI to pick up a pituitary adenoma. In a pituitary adenoma, we do a wipe sequence to pick up a smaller lesion and delineate it better. Genetics can be seen in Cushing's, especially in the younger age group with MEN1 and Dicer syndrome, and the adrenal Cushing's can be a part of PPNAD with their underlying genetics and families. And this case of Cushing also had a PHPT and a pancreatic NET, and was a case of MEN1 syndrome. From the same pathway of cortisol, if we go ahead, this was a young boy who was going to Goa on a holiday. They came to Mumbai airport, and he had a hypokalemic paralysis, and he was sent to the hospital. He was admitted with a hypokalemic paralysis, seen by a neurologist, was found to have hypertension. We did the whole LCMS steroid profile. The renin was low, aldo was low. So it was a case of low renin, low aldo hypertension. So initially I was thinking on the lines of Liddle's. The genetic report turned out to be case of apparent mineralocorticoid excess, and then we did a cortisol and a cortisone. The ratio of F to E was 35, which usually is 3. So a low renin, low aldo hypertension is something what we are looking at, a case of mineralocorticoid excess. Again, going ahead in the same cortisol pathway, a lady with hirsutism having hypertension and a history of hypokalemic paralysis. She was also seen at another hospital, and they have also made a diagnosis of Liddle's for her initially. And the cortisol load was very high. That gave a clue to the diagnosis, and the ODS was high. And so it turned out to be a glucocorticoid resistance syndrome. So in the cortisol axis, is whether the cortisol is more, or it is not metabolized, or it is not acting on the receptor, can lead to hypertension in these cases. In the same axis from the fasciculator, it is not only the cortisol, the fasciculator axis may be making deoxycorticosterone and corticosterone. So those are the aldosterone mimics. And in this pathway, with the low renin, low aldosterone, we have discussed about AME and the glucocorticoid resistance. But the specific cases of CAH like 11 beta and 17 alpha also present like this. Like in this lady with PCOS, having hypertension, and LCMS profile revealed There is a block in 11 beta. The deoxycorticosterone was elevated. So low renin, low aldo hypertension. Non-classic CH due to 11 beta, HOD, 11 beta hydroxylase deficiency is the diagnosis in this case. Similarly, two sisters with hypertension and primary amenorrhea and hypokalemia, both having similar presentation. If you look at the LCMS profile, you can make out the block is in the 17 hydroxylase and a lyase pathway, leading to the excess deoxycorticosterone and corticosterone, leading to low renin, high aldo hypertension in these young ladies. Moving to the last part, the salt hormone, which would be excess usually in form of micronodules to macronodules to an adenoma or a classical Conn syndrome. That is what we call as a primary hyperaldosteronism. And with the availability of chemi-based renin and aldo assays, we have learned this now pretty well over the last 5 to 7 years. This is a classical case of Conns with low renin. In the presence of low renin, there is no business for the aldosterone to be existing. The aldosterone is autonomously being produced by these hypodense glands, which are hypodense nodules, which are seen on the CT scan, and they are very lipid rich and bright yellow when you do a gross for them, and you need a laparoscopic adrenal surgery for the same. You have a spectrum again. So this is a case of low renin, high aldo. And what are the cutoffs for it? The cutoffs for it would be the renin is suppressed and aldo more than 15 is what we call as high, and we confirm it with a saline suppression with an aldo more than 6. Regarding drugs, if the renin is suppressed, we are okay with it unless we are on a centrally acting drugs of antihypertension, which are rarely on board. But if we are in doubt, we will stop the drugs and then do the test. And this is one condition of hypertension where we, before doing the test, we try to liberalize the salt rather than restrict the salt, and need a counseling of the patients because the GP will again counter whatever we say to them. Simply, if we are lucky, we'll find out the adenomas or bilateral hyperplasias. But at present, we may have to go for adrenal venous sampling in few of the cases, which is doable, and we have done our learning curve and it is doable easily these days. And there may be a genetic cause. Most of them are somatic mutations. The familial mutations like glucocorticoid remediable hypertension and the CACNA-CA is the one, the type 4 is one which is seen in our cohort, the max. But the somatic mutations are seen in most of the adenomas, whatever we operate. So just to summarize, adrenal gland is the seat of hypertension. If it is a salt hormone excess, I have to do a low renin, high aldo. There could be specific subset with low renin, low aldo, where there are aldosterone mimics like deoxycorticosterone, Cushing's, ODS cortisol, and a clinical suspicion. Pheoparaganglioma imaging, because many of them will be picked on incidentally. And if you have to do a test, it's a simple supine half an hour plasma-free norepinephrine as a single test for screening. And we have to keep these things simple because we are not diagnosing everyone. We don't want to miss them. So it has to be kept simple as a screening tool. So my conclusion will be we should suspect them and use the right tools. And rather than to create apprehension in the patient's mind, idea is to keep it simple and do it simply. Thank you.